Hi class, my name's Elizabeth Moran and I'm doing my presentation on adrenal disorders, specifically Addison's and Cushing's syndrome in children. The basics for Addison's and Cushing's disease is that Addison's doesn't produce adequate amount of cortisol, so it's on the needs to add a hormone side, and Cushing's syndrome has extra cortisol, so it's on the has an extra cushion of hormones side of thing. The epidemiology of Addison's disease. Typically it costs someone $2,200 per year, and that's mostly based on the cost of the hormone replacement. It also includes the cost of hospital visits and doctor visits. And there are approximately 93 to 144 cases per million in developed countries, 4.7 to 6.2 per million in the Caucasian population, with an increase in 4.4 to 6 new cases per million per year. Mortality rates are much higher in the pediatric male population, as you can see in the diagram on the right. And then 80 to 90% of all Addison's cases are caused by the destruction of the adrenal gland. And then adrenal insufficiency from adrenoleukodystrophy only affects males. It's X-linked. And then Addison's disease highly affects the community surrounding these little pediatric population. Parents and caregivers need to be educated on adrenal crisis and when to dose these little ones. And then they also need to be doing risk assessment and preventing, high stress situations for these kids. Addison's disease is the inability to produce adequate amounts of cortisol, which can result in poor physiological response to illnesses, trauma, and other stressors. An adrenal crisis may follow, causing hypoglycemia, shock, and electrolyte abnormalities. Consequences can be severe and include coma, organ damage, and death. Adrenal insufficiency carries the risk, especially with children, with severe morbidity and mortality. Total mortality with children can be 3 times greater with adrenal insufficiency than in the general population. So the little emblem to the side says keep calm and stress dose. Stress dose is what you do when there's a kind of a big stressor happening. There are 2 categories of Addison's disease or adrenal insufficiency in children. Primary is congenital, and it only affects the adrenal glands. Secondary is acquired, and it affects the hypothalamic pituitary adrenal axis. That's the conversation that the hypothalamus has with the pituitary gland that then talks to the adrenal gland, and then the adrenals respond by communicating back with both of them in a feedback system. The goal is to keep the cortisone at a normal level. So if that feedback system is broken, then cortisone drops. On the right-hand side, you can see the different causes of primary and secondary Addison's disease. Congenital adrenal hyperplasia is by far the most common cause in primary Addison's disease. And then below them is a list of different things that can kind of eat away at or destroy the adrenal glands. And then in secondary Addison's disease, there's a number of things that can kind of mess with that communication pathway, the hypothalamic pituitary adrenal pathway. This slide talks a little bit more about the anatomy. So as you can tell, the kidneys, on the top of the kidneys is the adrenal glands, and if we slice them open, we have the inside is the medulla, and the outer part is the cortex of the adrenal gland. The medulla produces adrenaline, and the outer region, the cortex, produces adrenal steroid hormones. The 3 types of steroids produced are the glucocorticoids, which is a sugar hormone. Think, ways that we mediate sugar, hyper and hypoglycemia. Mineral corticoids are the saltwater hormones. Think renin, angiotensin system. And then the androgens are the male hormones. and those have some physiological effects on the female anatomy, and we'll see some more of that later on. This is another diagram showing the normal chain of events that would include the hypothalamus producing corticotropin, talking to the pituitary gland, and the pituitary gland excreting adrenocorticotropic hormone, talking to the adrenal gland. And then the adrenal gland produces cortisol, and that speaks both to the pituitary and the hypothalamus. The cortisol and the adrenocorticotropic hormone work in balance, so when the cortisol is too high, it turns off the adrenocorticotropic hormone, hopefully returning the cortisol to a normal level. The opposite is true as well. When the cortisol is low, the adrenocorticotropic hormone increases until cortisol is normalized. Cortisol, like we've talked about, is essential for general well-being, day-to-day activities, and any stressors. It's also vital in the body's response to stress and is involved in maintaining normal physiologic functions, such as blood glucose levels, blood pressure, and blood volume. Through this feedback mechanism that we've talked about, the hypothalamic pituitary adrenal axis, secretion of cortisol increases up to 6-fold during times of stress. With Addison's disease and the lack of adequate production of cortisol, the result is poor physiologic response to illnesses, trauma, and other stressors, and this may create an adrenal crisis. Cortisol works to maintain blood pressure through a variety of mechanisms. It's responsible for converting norepinephrine to epinephrine in the adrenal medulla. Cortisol also improves capillary integrity and contributes to vasoconstriction by inhibiting atrial wall nitric oxide synthesis. Cortisol also has an inotropic effect which improves cardiac output. Glucocorticoids enhance the vascular and cardiac action of epinephrine and norepinephrine. In conditions of increased metabolic demand, cortisol promotes sodium and water retention. Mineralocorticoids contribute to normal blood pressure and normal blood volume by promoting sodium and water reabsorption in the distal tubules and collecting ducts of the kidney. Adrenal insufficiency in children typically presents with some nonspecific symptoms, such as fatigue, malaise, abdominal pain, weight loss, nausea, and vomiting. Physical symptoms appear later as manifestations of the disease and include hypotension and hyperpigmentation. Females with the classic form of congenital adrenal hyperplasia, which is a primary Addison's disease, are born with ambiguous external genitalia. I attached a picture here. This is caused by excessive amounts of androgen present in utero. In these cases, surgery is often necessary to correct the external genitalia. Classic biochemical signs include hyponatremia, hyperkalemia, hypoglycemia, and ketonemia. A life-threatening adrenal crisis can be the first presentation of a patient with adrenal insufficiency, with a sudden onset of vomiting, abdominal pain, malaise, severe hypotension, and hypovolemic shock. This acute presentation is usually precipitated by a physiological stressful event, such as surgery, trauma, or infection. It's worth noting that the hyperpigmentation and the hyperkalemia occur inconsistently, and just because someone does not have those, you should not rule out the diagnosis of Addison's disease. Differential diagnosis. One of my diagnoses would be chronic fatigue syndrome, ruling in the presentation with fatigue and fever, and ruling out because a person with chronic fatigue syndrome will typically have a purple discoloration in their anterior tonsils and then a left axillary node involvement. Both problems, though, the chronic fatigue and the Addison's disease, present really vague, so I think they might be similar. My second differential diagnosis would be the eosinophilia, ruling in because of the fatigue, fever, weakness, and erythroderma, and ruling out because of exertional dyspnea, muscle pain, rash, and visual changes. My third differential diagnosis is familial glucocorticoid deficiency, ruling in because of hypoglycemia, shock, abdominal symptoms, changes in mental status, absence of weight gain, lethargy, and hyperpigmentation of the skin. Ruling out because of palpitations, anxiety, shakiness, hunger, sweating, pallor, vision changes, and recurrent or severe infections. The labs and diagnostics involved with diagnosing primary and secondary Addison's disease look differently. For primary Addison's disease, you're going to see an elevated adrenocorticotropic hormone along with a low cortisol level. The serum urine cortisol levels might be undetectable, so we can't use those to diagnose. We do look for a cortisol response to an adrenocorticotropic hormone stimulation test. And in congenital adrenal hypoplasia, we're looking for an elevated 17-hydroxyprogesterone level, along with subnormal cortisol levels, low aldosterone levels, and an elevated renin level. Secondary Addison's disease looks for both the adrenocorticotropic hormone and the cortisol level to be low. Other confirming tests for the secondary Addison's disease include the insulin tolerance test, low and regular adrenocorticotropic hormone stimulation test, corticotropin-releasing hormone stimulation test, glucagon stimulation test, and the overnight metarapone testing. Typical lab findings for both would be hypoglycemia, mild anemia, lymphocytosis, eosinophilia, mineralocorticoid deficiency, low aldosterone, elevated renin, hyponatremia, hyperkalemia, and acidosis. The goal of treating Addison's disease is to replace the hormones that are not being excreted by the adrenal glands. Usually that starts with corticosteroids, including hydrocortisone and prednisone. They can be taken orally IV, depending on the child's condition, and they'll probably have to take them for the rest of their lives. Treatment can also include fludrocortisone that helps with the sodium and potassium levels. It's important to not under or over-treat. It'll cause the same kind of problem. And then the typical dosage is 2 to 3 daily hydrocortisone, but it's also based on the child's surface area. And then be careful with long-term glucocorticoid therapy. It needs to be reduced gradually to allow recovery of the hypothalamic pituitary adrenal axis. The stress dose schedule is right here. And then for surgery, those females that are born with ambiguous external genitalia. Health promotion for those with Addison's disease. Some of the keys are promoting early intervention. So if you can see a crisis is coming or something stressful, to either avoid it or stress dose. Carry a steroid therapy card that can have personal information, next of kin, dosages, oral, rectal, intramuscular, and then guidelines for staff who might be unfamiliar with your situation. And then promoting sick days. So if someone is sick, to immediately just choose to stay home. And then identifying risks for adrenal crisis and avoiding those. Know when to stress dose and don't be afraid to do it. Educational tools, whether it's a doctor talking to a patient, encouraging patients and their family to go to support groups, handing out booklets, and then age-appropriate education. So teenagers typically prefer learning via the internet. Several studies I looked at the quality of life for patients and parents of children with Addison's disease. Parents themselves do not experience a lot of fear about the occurrence of an adrenal crisis, and they feel that they can influence the condition of their child. Quality of life of the children is not necessarily reduced, but the children do experience several day-to-day health-related problems, but it doesn't seem to affect their daily activities and participation in society. The parents experience pretty low burden when it comes to their children. Children participate well in school and leisure time. However, few of them carry a crisis card or an emergency injection with them. Improvements can be made concerning the measures parents and children must take to prevent an adrenal crisis as well. One idea is to provide more easy-to-carry or wear identifiers, like those in the pictures here, or an injector with instructions. There were some problems when it came to teens being more involved with their care, but their medication adherence was low, unbeknownst to their parents. Now we're going to talk about Cushing syndrome, the entire other end of the spectrum, where we have far too much cortisol present. Epidemiology. 2 to 5 new cases are presented per million per year. 10% of these cases are children. Endogenous Cushing syndrome is rare with an incidence of 0.7 to 2.4 cases per million population per year in the U.S. There's 2.4 cases per million in Vizcaya, Spain, and there's 79 cases per million per year in New Zealand. An average age of presentation is typically 14.1 years old. The standard mortality ratio is 3.7 after the initial presentation. There's a female-to-male predominance that decreases with younger age. The diagram on the right shows us the younger age, the more common it is for males. The average overall cost per person per year is nearly $35,000. There are 2 causes of Cushing syndrome. The first one is exogenous, coming from some outside source, and then the other one is endogenous, coming from somewhere inside of us. Typically, Cushing syndrome comes from prolonged exposure to excessive glucocorticoids, cortisol. And we just got done talking about how we don't have enough in Addison's disease, so this makes sense. There's far too much cortisol. So some exogenous sources, adrenocorticotropic hormone secreting pituitary tumors, and then we have adrenal tumors and ectopic adrenocorticotropic hormone or corticotropin releasing hormone tumors, which is rare. Some endogenous sources are adrenocorticotropin hormone pituitary adenoma or carcinoid tumors. There are several different pathways that a patient can have Cushing syndrome. The diagram on the left shows us at a very young age, little ones can have adrenal hyperplasia secondary to McCune-Albright syndrome, with an average presenting age of 1 and 1.2 years old. The next one is adrenocortical tumors, presenting typically around 4.5 years old, ectopic adrenocorticotropic hormone syndrome, typically showing around 10 years old, nodular adrenal hyperplasia, typically presenting at 13 years old, and then Cushing's disease, a subset of Cushing syndrome, typically presenting around 14 years old. On the diagram on the right, we're showing all the different pathways that a patient can get Cushing syndrome. Exogenous steroids are the most common, and then there's adrenal tumors, nodular adrenal hyperplasia, ectopic tumors that secrete adrenocorticotropic hormone, and pituitary hormones. And these all interfere with the communication of all the different hormones, just like we talked about in Addison's disease. Signs and symptoms of Cushing syndrome. This slide shows a physical diagram of a lot of the symptoms we're going to list on the left. Truncal obesity, slow growth in our pediatric population, excessive hair growth, buffalo hump, moon face, ecchymosis, red abdominal striae, easy to bruise, poor wound healing, acne, hirsutism, delayed sexual development and amenorrhea, hypertension, glucose intolerance, fatigue, lack of height gain with persistent weight gain, that one's really common, and then personality changes. Some that have been noted include compulsive behavior, overachievement in school, moodiness, irritability, mania, and psychosis. Differential diagnoses I came up with. The first one is simple obesity. Oftentimes, obese patients show stretch marks, just general weight gain, typically have hypertension, and then sometimes they have a problem with their glucose intolerance. Things that they will not have, they won't have a moon face, which is a pretty common distinction with Cushing syndrome. They won't have any hirsutism. They probably won't have any personality changes, and then they won't have that typical sign of stunting of height. Bulimia patients typically are overweight. They do have acne, and sometimes they don't have their period, and then sometimes they have poor wound healing. And then they will probably have hypotension, edema, hair loss, and bilateral parotid enlargement, and dental damage. Those are not common in Cushing syndrome. And then my third differential diagnosis is depression. I ruled it in because in common they would have fatigue, sometimes personality changes, the ability to think, not be able to think clearly, suicidal, and weight gain. And then I ruled it out because depression typically would have sleep disturbances, psychomotor agitation, and they wouldn't show signs of some of those things we would see in Cushing syndrome, including the stunting of the height, the ecchymosis, and the moon face. In diagnosing Cushing syndrome, there's a few tests we can do. One is a urinary-free cortisol excretion test. It's a 24-hour urine collection daily for 3 days. It provides an integrated assessment of cortisol secretion over a 24 adrenocorticotropic hormone period. The second test is a serum cortisol. It's taken 3 times a day to assess a circadian rhythm. Determination of midnight cortisol in the sleeping child gives the highest sensitivity for the diagnosis of Cushing syndrome. The next test is a low-dose dexamethasone suppression test. Sensitivity for Cushing syndrome and an even higher specificity for the exclusion of this diagnosis. The next test is a salivary test. Educate the patient on optimal timing of specimen collection while taking into account their normal sleep-wake cycle. Avoid stressful experiences the evening of the test, and avoid any topical hydrocortisone creams and ointments. This test is 90% sensitive, and specificity makes it a highly useful test, especially in outpatients and children. You can also do an MRI of the pituitary gland. Any large mass greater than 6 millimeters strongly suggests a diagnosis of Cushing syndrome. In treating Cushing syndrome, treatment might include surgical removal of growths on the adrenal glands or the adrenal gland itself. Choosing a neurosurgeon experienced in treating Cushing syndrome in children is likely to significantly improve the chance of effective and curative therapy. There are medications available as well that block the excessive production of certain hormones. One of those is mifepristone. It's the most promising option for long-term medical treatment of refractory Cushing syndrome in children. Pituitary radiotherapy is available as well. Some long-term effects are promising and others are not. 1 year after being cured, most children have decreased their body weight and their body mass, and their height and growth velocity have increased. However, the final adult height is typically compromised. Normalization of body composition in children and adolescents may not occur. Adverse long-term effects of chronic hypercortisolemia include residual negative effects on their waist circumference and body mass index standard deviation. Several studies report a significant improvement in blood pressure. Bone density shows dramatic improvement. However, in children, cognitive decline occurs despite reversal of brain atrophy after remission. Goals in promoting health for a Cushing syndrome child would be optimizing their growth, pubertal development, normalizing body composition, and promoting psychological health and cognitive development. Just like we just talked, some of this may or may not occur. Typically, some functions remain below normal: physical function, role physical, global health perception, and emotional impact.